A very good evening, dear super specialty aspirants. Today I'll be discussing on the plastic surgery questions in the recently held NEET Super Specialty 2025 exams. I'm your plastic surgery faculty, Dr. Vijay. I'm a professor at the Savitha Medical College. Okay, the first question today, which we are going to discuss, is a very simple question. A neonate with a unilateral cleft lip, which muscle is most likely affected? The four options given were orbicularis oris, levator leviae superioris, depressor angularis oris, and mentalis. So it's a very obvious answer, orbicularis oris, because orbicularis oris is a circular muscle around the mouth. It is the main muscle forming the lip, and it decussates in the midline in the lower aspect. Okay, levator leviae superioris is mainly elevates the upper lip. Depressor angularis depresses the angle of the mouth, and mentalis is mainly present over the chin, which is mainly used for pouting out or everting the lower lip. Cleft lip and palate, as we all know, it's a very important topic. The incidence of lip and palate is 1 in 600 live birth. The incidence of isolated cleft palate is 1 in 1000. So, cleft lip and palate is more common. Lip and palate predominates in male. Cleft palate alone predominates in females. And most commonly, the cleft is unilateral and on the left side 60% of the time. So, if you see the typical cleft lip and palate is present in 45% cases. Isolated palate is present in 40%, and lip alone is present in 15% cases. Lip and palate is more often genetic. If a first degree relative is affected, nearly 1 is to 25 live births, there is a chance of cleft lip in the subsequent childs. Genetic influence is very significant. Whereas cleft palate alone, environmental factors exert a greater influence, like use of steroids, diazepam, phenytoin, and maternal epilepsy. They all contribute for the cleft palate formation. And cleft palate is most commonly associated with syndrome rather than a cleft lip and palate. So the various syndromes associated with cleft lip and palate are Stickler's, Sprinson's, Downs, Appert's, and Treacher-Collins syndrome. But there is only one syndrome which is associated with the cleft lip alone. It is called as a Van der Woody syndrome, in which there are multiple lip pits. Peri-Robbins syndrome is more often a sequence in which there is retronothia, glossoptosis, and early respiratory difficulties. And isolated cleft palate is not a part of the sequence. Isolated cleft palate is also a finding in Peri-Robbins syndrome. So you can see in the unilateral cleft lip, the nasolabial and the bilabial rings. Basically, you can see the muscles of the face are divided into A, B, and C. This is the old Balian nerve. Okay, A is the nasolabial ring, B is the bilabial ring, C is the labiomental ring. So there is a nasolabial and the bilabial ring disruption on one side, which is mainly the orbicularis oris, asymmetrical deformity, displacement of the nasal skin onto the lip. There is a retraction of the labial skin and the changes to the vermilion and lip mucosa. In bilateral cleft lip, the deformity is symmetrical. Two superior muscular rings are disrupted on both sides. There is a flaring of the nose. There is a protrusive premaxilla, and the area of the skin in front of the premaxilla, divide of the muscle, is also called as a prolabium. So the prolabium is usually used in reconstruction of the philtrum for bilateral lip correction. So protrusive premaxilla is the part in which is anterior to the incisive foramen. So the primary palate, the upper four incisors, and the philtrum or the prolabium, they all form the premaxilla. Clefts are anatomically classified as unilateral cleft lip, in which there is a cleft lip on one side, bilateral, in which the cleft lip is on two sides, incomplete if there is no nasal floor extension, complete if there is a nasal floor extension. So this is an incomplete unilateral cleft lip on the left side. This is a complete unilateral cleft lip on the left side. This is a bilateral incomplete cleft lip, and this is a bilateral complete cleft lip. Similarly, palate, this is a normal palate, and incomplete cleft palate means there is a partial clefting of the soft palate and the secondary palate. Secondary palate means posterior to the incisive foramen, which does not involve the primary palate or the alveolus. This is called as the incomplete cleft palate. Complete cleft palate means the cleft extends the entire length involving the primary and the secondary palate. So you can see here also the clefting is there. So primary palate is the palate which is anterior to the incisive foramen. Here you can see, and secondary palate is the palate which is posterior to the incisive foramen. And here there is a hard palate, soft palate, etc. Whereas anteriorly you have the primary palate and the upper four incisors. All these violet areas, they are all called as the premaxillae. Soft palate consists of a lot of muscles, the tensor palate, levator palate, palatopharyngeus, and the palatoglossus and the musculus uvulae, out of which levator palate is the most important muscle, which is causing the touching point of the palate to the posterior pharynx and causes the voice production. Usually, the fibers of the soft palate are decussated in the middle like this, but when there is a cleft palate, the fibers are abnormally attached to the posterior part of the hard palate, especially here. So, the attachment of the muscle fiber to the posterior edge of the hard palate is present in cases of the cleft soft palate. The schedule of management of the cleft lip is commonly asked. Okay, the prenatal diagnosis can be done and the prenatal counseling can be given. Okay, at 3 months of after birth, lip surgery can be done. At 9 months, the palatal surgery is done before the development of the monosyllable words. At 2.5 years, speech evaluation has to be done. And if at all there is a speech problem, velopharyngeal insufficiency correction can be done. 7 to 9 years before the eruption of the canine tooth, the alveolar cleft is corrected, mostly with a secondary alveolar bone grafting. Orthodontia correction is done later, and by 17 years, orthodontic correction is done. The second question which was asked is the image of a muscle like this is given, and they asked what is the type of the muscle flap. Muscle and musculocutaneous flaps are divided into 5 types by Mathis and Nahai according to the vascularity. This is a type 3 flap in which there are two dominant pedicles. So before going to the classification, we should understand what is a dominant vascular pedicle, minor vascular pedicle, and segmental vascular pedicle. Dominant vascular pedicle is a pedicle which can sustain the entire muscle as a flap. Minor vascular pedicle is a pedicle which cannot sustain the entire muscle, only can sustain 75 to 80% of the muscle, and the distal 20% cannot survive on the minor vascular pedicle. Whereas the segmental pedicles, in segmental pedicle, there are multiple unrelated sources of blood supply, and each one of them can supply nearly 30%. So muscle flaps are classified as type 1 to 5 based on these concepts. In type 1, there is a single pedicle. So the tensor fasciae lata is a classical example of type 1 flap. There is a single dominant pedicle. Also, a gastrocnemius flap is an example of a type 1 flap. Type 2 is one dominant pedicle and one minor pedicle. Okay, example is gracilis flap. And the type 3 is two dominant pedicles. You can see the two dominant pedicles here. The main advantage of the type 3 flap is a split muscle flap can be used in case of a type 3 flap. In type 4 flap, segmental pedicles are there. The most common example is a sartorius. And in type 5, there is a one dominant pedicle and multiple secondary segmental pedicles just opposite or contralateral to the dominant pedicle. Which of the following is a false statement in lymphoscintigraphy done for lymphedema? 1. It differentiates between primary and secondary. 2. It has a smaller exposure to radioactivity. Migration of the radiotracer within the skin and subcutaneous tissue is monitored with a whole body camera. Edema secondary to the venous disease. Isotope clearance is usually rapid. So this has been taken directly from the latest Saviston. Verbatim, all these four statements are present, and the answer is it cannot differentiate primary and the secondary lymphedema. So the various diagnostic tests for lymphedema, if to find the reason for a suspected lymphedema, the best test is nothing but a lymphoscintigraphy. In lymphoscintigraphy, okay, once the lymphoscintigraphy confirms that the lymphatic drainage is delayed, the diagnosis of a primary lymphedema should be made only after ruling out any neoplasia or the nodal enlargements in the regional or the central nodes. And therefore, this test cannot differentiate between primary and the secondary lymphedema. And if a more detailed interpretation of the lymphatic channels is required, we have to go for contrast lymphangiography. So in lymphoscintigraphy, what do we do? What do we do in lymphoscintigraphy or isotope lymphography is we basically assess the lymphatic function by quantiating the rate of clearance of a radio-labeled tracer. Okay, so what we do here is, first of all, we inject a small amount of radio-labeled human technetium or a labeled technetium 99 labeled human technetium 99 labeled sulfur colloid or radioionated human albumin into the first web space. The migration of the radio tracer within the skin and the subcutaneous tissue is monitored by a whole body camera. So that is also true. It produces clear images of the major lymphatic vessels in the leg. Okay, and the amount of the radioactivity at inguinal nodes after 30 minutes and 60 minutes is done using the gamma camera. A value less than 0.3% of the total injected dose at 30 minutes means it is diagnostic of lymphedema, because normally nearly 0.6 to 1.6 percentage of the tracer intake will be there at the lymph nodes. Okay, so you can see in this picture, on both the legs the tracer has been given, but on the right side the tracer has been clearly cleared into the right inguinal lymph nodes, whereas on the left side the clearance is delayed, which is shown by the dermal black flow. So these are the tracer which is present in the dermis, and also the inguinal lymph nodes are not enlarged. So this shows that this is a case of lymphedema. So this is the primary use of a lymphoscintigraphy. Okay, but if the isotope clearance is abnormally rapid, it means it is a varicose vein disease, because and the edema is secondary to a venous disease. Okay, it is a simple and safe test, and approximately 5 millicurie of radiation is exposed. Direct contrast lymphangiography is one more test in which the lymphatic anatomy is taken. Here we have to expose the lymphatics in the dorsum of the foot and cannulate the lymphatics and inject a iodized oil. 7 to 10 ml of contrast is ideal for the lower extremity evaluation and 4 to 5 ml for upper extremity evaluation. The complications include damage of the visual lymphatics, allergic reactions, and pulmonary embolism. New test is contrast magnetic resonance lymphangiography, which is performed after intracutaneous injection of gadobenate dimeglobin into the interdigital webs of the dorsal foot. It is capable of visualizing the anatomy and the functional status of the lymphatic flow transport of the lymphatic vessels and lymph nodes of the lymphedematous limb in both primary and secondary lymphedema. Bioimpedance spectroscopy is a new test which is based on the concept that the flow of the electrical current in a particular region of the body is inversed in relation to the type of the fluid tissue present within it. So, with the early lymphedema and increase in interstitial fluid, the bioimpedance decreases. Okay, the sensitivity and the specificity has been found to be 100% in this test. Other than this, artificial intelligence can be used, and non-contrast magnetic resonance lymphangiography are the latest tests. So this is a summary about the various diagnostic tests like lymphoscintigraphy, lymphangiography, MRI lymphangiography, artificial intelligence, bioimpedance spectroscopy, and non-contrast MR lymphangiography. An image of mallet finger is given, and the question was asked. So when you talk about mallet finger, we have to basically think about the extensor tendon injury in the hand. Zone 1 is extensor rupture at the DAP joint. Zone 3 is over the PAP joint, and zone 5 is over the MCP joint. Zone 2 and 4 is over the MPX and the PPX, and zone 6 is over the metacarpal. Zone 7 is underneath the retinaculum. Zone 8 is proximal to the retinaculum, and zone 9 is at the proximal to the musculocutaneous junction. So you can see all these zones. In the thumb, the zones differ a little bit. So when there is a rupture of the zone 1 tendon, it is called as a mallet finger because there is an unopposed action of the flexor digital profundus and the finger flexes like this. When there is a rupture of the tendon at the PAP joint level, there is a botanist deformity because unopposed flexion of the PAP joint leads to the sagging of the checkrane ligaments, that is the lateral terminal slips on either side of the volar aspect of the PAP joint, and therefore there is a DAP joint extension. That is called as the botanist deformity. Whereas when there is a rupture at the zone 5, there is a drop finger. So the presence of the juncture mainly prevents the proximal retraction of EDC tendon, and extensor tendon repair is usually done with the horizontal mattress unless if the figure of 8 mattress stitches, and if it is circular, then you can go for a modified Kessler's. So mallet finger is when there is extensor tendon avulsion at the DAP joint. If the bony fragment is 50% or more of the articular surface, then there is a volar subluxation. If there is, then there is a volar subluxation of the DAP joint. Then we have to go do for a open reduction and internal fixation. Whereas if the piece of bone is less than 50% and DAP joint is not subluxated, then 6 weeks of splinting is enough. Okay. Here, fixation has been done because more than 50% of the articular surface is ruptured. Whereas in the A and B, A is called as a stack splint. Okay, B is a dorsal splint for mallet finger. C and D are for botanic deformities, wherein the DAP joint is free and the PAP joint is immobilized. Question 5, an image of Charles procedure is given. What is the true statement? Circumferential excision of skin and subcutaneous tissue done in advanced cases with skin damage and infection. A graft uptake is 58% and it is a staged procedure. So out of which our answer is it is done in cases with the skin damage and infection. Graft take nearly 85% is there. It is not a stage, it is single stage. There is excision of not only skin and the subcutaneous tissue, even the deep fascia is excised. Operative treatment is usually done for stage 2 or stage 3 lymphedema who have severe functional impairment, recurrent lymphangitis, and severe pain despite medical therapy. There are two types of treatment, reconstructive and excisional. Excisional operations are viable only for patients without residual lymphatics of adequate size for reconstruction. If some residual lymphatics are there, you can do a reconstructive procedure, which I will be discussing in further slides. So for patients with a stage 2 recalcitrant or a early stage 3 in whom edema is moderate, skin is relatively healthy, an excisional procedure can be done. Homan described a palliative procedure in which there is a staged subcutaneous excision, whereas in Charles it is a single stage excision. So in Homan, a long medial incision is given, and 1 centimeter thick flaps are raised, and the excessive subcutaneous tissue is excised. Okay. So after excising, while raising the flaps, the sural nerve is preserved, and after excising the excess lymphatic tissue, the flaps are closed. A second stage is done if further edema is there, and it is usually done 3 to 6 months later in the lateral aspect of the limb. 80% of the patients undergoing this excision have long-standing good results, improved function extremity contour, and wound complications were seen only in 10%. So this is the Homan's procedure, or the previously called as a Condolian procedure. Whereas in Charles procedure, when lymphedema is extremely pronounced and the skin is absolutely unhealthy, it is a classic excisional operation, a complete circumferential excision of the skin, subcutaneous tissue, and the deep fascia of the leg and the foot is excised. It is done in one stage, and full thickness graft, usually from the excised skin itself, is done. This is also very specific in Charles procedure. Skin graft is nearly 88%, but wound infections can occur. So here, if you can see, the deep fascia also such removed. Okay. So between 10 to 15% graft loss is there, and other complications like sloughing, excessive scarring, recurrent infection, and hyperkeratosis and dermatitis are also present. But these complications are more when the graft is taken from the thigh rather from the excised fat skin, and sometimes even the grafted skin can lead to other changes and amputations might result. So that is the summary of Homan's procedure or the Condolian procedure and the Charles procedure. Both are reconstructive procedures, whereas both are excisional procedures, whereas the reconstructive procedures I will be discussing in the further question. Further, a patient who is chronically bedridden for 3 months has a pressure sore over the gluteal region. He is planned for flap reconstruction, which pre-op investigation is done. So before a flap reconstruction, we have to assess what is the area in which the ulcer is extending, whether any osteomyelitis is there, joint extension is there. So it is about the traversion of the ulcer, and therefore MRI is the best test. So when external pressures of more than 60 millimeter of mercury for 2 hours are there, it leads to irreversible tissue damage because it can lead to interstitial ischemia and inability for the blood to perfuse. The Braden scale is usually used to predict the pressure sore. National Pressure Ulcer Advisory Panel is used as a staging system. Stage 1 is the skin is intact with a non-blanchable redness in a localized area over a bony prominence. You can see a pictorial representation in the adjacent tissue. So non-blanchable redness is the grade 1. Stage 2, there is a partial thickness loss of the dermis presenting as a shallow open ulcer with a red pink wound bed without slough. Stage 3 is a full thickness tissue loss and subcutaneous fat may be visible, but bone, tendon, or muscle is not exposed. This is stage 3. Stage 4 is full thickness loss with exposed bone, tendon, or muscle. Suspected deep injury is a stage in which a purple or a brownish maroon localized area of discoloration and an intact skin or a blood-filled blister is there due to damage of the underlying soft tissue from pressure or shear. This area may be painful, firm, mushy, and the wound may evolve and become covered by a thin eschar. Whereas unstageable means there is a full thickness tissue loss in which the base of the ulcer is covered by the slough and which is by slough which is yellow, grey, green, or by eschar which is tan, brown, or black in the wound bed. Until the base of the wound is exposed, the true depth and therefore stage cannot be determined. So this is called as unstageable. So suspected deep tissue injury and unstageable are also two important stages. Suspected deep tissue injury is a purple maroon localized area of discolored intact skin. Whereas unstageable means ulcer is there, it is covered either with a slough or a eschar. So in case of sacral pressure source, gluteal muscle flap is commonly used as a rotational or as a VY advancement flap. Here a bilateral VY musculocutaneous advancement flap is done. We all know the gluteus muscle is a type 3 flap with the two dominant pedicles. Ischia ulcer, in which an inferior gluteus maximal rotational flap is done. Inferior gluteal fasciocutaneous thigh, VY hamstring, gracilis, TFL muscle is also used. So this is the ischial ulcer. Here a TFL flap is used for ischial ulcer. Graded trochanter pressure, again local fasciocutaneous TFL, inferior gluteal thigh flaps are used. So prevention is the best instead of the cure in case of the pressure ulcer. So in a bedbound patient, he should be turned at least for every 2 hours, and the patient who is wheelchair bound, they have to lift them off the seat at least for 10 seconds for every 10 minutes. A woman who previously underwent MRM developed upper limb lymphedema. She is now planned for lymphaticovenous anastomosis. LVA belongs to which category of surgical management? We all know the lymphaticovenous anastomosis belongs to the super microsurgery group of management. So basically, I initially told surgical options for lymphedema can be divided into reconstructive and the excisional procedures. Excisional procedures are the Homans and the Charles procedure. Reconstructive operations are done for patients with a proximal obstruction, either due to a primary cause or a secondary cause, with the preserved dilated lymphatics in the extremities. In these patients, the dilated lymphatics is anastomosed to the nearby vein, in which it's called the lymphaticovenous anastomosis or lymphaticovenous bypass, or to a transposed healthy lymphatic channel. So here you can see A, it's a lymphaticovenous anastomosis, and in B there is an invagination of the lymphatics into the vein, and in C the lymphatics is anastomosed to a vein graft, multiple vein graft. The most common candidates for a reconstructive procedure are upper extremity lymphedema, secondary to axillary lymphadenectomy, usually MRM, due to CA breast. Patients with the leg lymphedema, secondary to inguinal or pelvic lymphadenectomy again, and treatment of selected lymphedema patients with lymphovenous anastomosis, lymphovenous bypass, or lymphatic bypass have usually resulted in 30 to 80% success with an average initial reduction in excess limb volume of 30 to 84%. New surgical strategy involving the lymph node transplantation are also used successfully, wherein we can take the supraclavicular lymph node or even the inguinal lymph nodes and do a free flap anastomosis. This technique involves completing also a gastroepiploic omental flap in which a free omental flap is done. An image of a giant congenital melanocytic nevi is given, and the question is asked. Nevus is a benign collection of pigment producing cells in the epidermis, dermis, or both. If it is present in the epidermis, it is called as epidermal nevi. If it is present in the dermis, it is called as a dermal nevi. If it is present in the junction, it is called as a junctional nevi. And when junction and epidermis spread, it is called as a compound nevi. So congenital melanocytic nevis are hamartomas of nevi cells. They are classified as small if it is size is less than 1.5 centimeters, as medium if the size is 1.5 to 19.9, nearly 20 centimeters. Large as more than 20, less than 50 centimeters, and giant as more than 50 centimeters. This classification is very important because the risk of melanoma in melanocytic nevi in case of small or medium sized lesion is less than 5%. In cases of large and giant cell nevi is 10%. And in case of malignancies in large and giant cell nevi, they typically occurs in the first 3 years of life. So, along with the melanoma risk, there is also leptomeningeal involvement, which can be found in MRI. There is a developmental disorders for the patient, and early excision and reconstruction is recommended for large and giant nevi. The various options for treatment of giants and giant nevi, larger nevi are serial excision, excision and grafting, excision and closure with distant flaps, and tissue expansion. Replacement with live tissue is the goal, and therefore tissue expansion is the mainstay of approach. This is a case in which an excision and the full thickness graft is done. B is an excision and D is final after the full take of the FTG. This is a serial excision wherein the central part of the lesion is excised, and once a scar is formed, after 3 weeks to 6 weeks, it is excised again and again after 3 to 6 weeks, and finally only a normal skin scar is there. This is a tissue expander, which is the best choice. Preoperative lesion, expansion of the tissue expander, and finally a good hair bearing scalp. This is the last question in which a X-ray of a patient with a newborn formation was given. Here you can see the newborn formation is mainly present like a subperiosteal reaction. If there is a solid, thick and smooth reaction, then it is often benign, usually osteoidostoma or healing fracture or venous stasis. If it is a laminar with an onion skin appearance, it is often subacute and even sarcoma can be suspected. If it is a sunburst or a spiculated, it is highly suspicious of malignancy. So in case of osteoidostoma, there is a central nidus which is surrounded by a dense, smooth, thick periosteal reaction. In case of osteosarcoma, it shows an aggressive sunburst appearance or a lamellated newborn formation. In Ewing sarcoma, onion peel appearance is there. In osteofibrous dysplasia, usually affects the anterior cortex of the tibia. A diffuse thickening is present. In adamantinoma also is undifferentiatable from the osteofibrous dysplasia. Fibrous dysplasia usually gives only cortical thickening. So it is mainly present fibrous osteofibrous. This particular case can be a case of osteofibrous dysplasias. It is a benign bone lesion, often causing ossifying fibrosis of the long bones. It is primarily present in the tibia, and it is usually present within the bone's hard outer layer of the cortex. It causes pain, swelling, bowing, or fractures, but often stabilizes with skeletal maturity. Diagnosis involves X-ray, which shows lucent lesions, and treatment is usually conservative as it is self-limiting in nature. So this is the summary of all the questions. So this is probably osteofibrous dysplasia of the long bones. And in congenital melanocytic nevi, tissue expander and closure is the best. And melanoma is a very high risk, and it is usually classified as uh, usually classified according to the size as small, medium, large, and giant. We also saw about reconstructive procedures in lymphedema, prevention of pressure sore, and national pressure ulcer scoring, which is very important. The fifth question is about the Charles procedure, in which the deep fascia is also excised. The graft is taken from the excised skin as a full thickness graft. And Homan's procedure is raising two flaps and doing as a two-stage procedure. Both are the excisional procedures in case of lymphatics. A mallet finger, if it is more than 50%, then we have to go for an open reduction internal fixation. Less than 50%, conservative splinting with a stack splint or a single dorsal splint is achieved. Lymphoscintigraphy cannot differentiate primary and the secondary lymphedema, but it is the test of diagnosis to diagnose lymphedema. If you are suspecting a case, types of flaps according to Matheson-Nahai. And finally, cleft lip and palate. In this particular case, the muscle usually gone is the orbicularis oris muscle. Thank you. This brings us to the end of the plastic surgery recall sessions. If there are any questions, you can ask. Thank you.